Go ahead.
Hi, this is Dr. Andrea Davis, and we are Expect More. And today we have my very prestigious friend who is extremely humble and so intelligent, Kristen Lehman. Kristen,
Hello.
welcome.
Hi, how are
Oh,
you? It's
so
good to be
happy
here.
to have
I know,
you here.
finally, right?
And this is our
So
first in-studio interview. So
being the guinea pig, paving a path.
that's
Totally
right,
fine with it. That's good.
like you always do.
Don't
So,
judge.
oh my
Don't
gosh.
judge.
But I mean, that's like the perfect intro
Uh-huh.
to how we
Right.
met anyway,
It's
which
been a
is
long time.
it has been a long time, more than 20 years at this juncture.
Yeah, actually it's more than 25, I think.
It
I'm
is.
sorry, but
It
it is.
is.
It's been a lot longer than that. When
It's
you think about
awful.
it, it's true.
That's awful, but true. And I'm very proud of that. So we met because you were the first and only PA at a one of our orthopedic referring practices when I was a new grad PT. So you kind of blazed a trail.
And that was in 2000. That was in 2000. So yes, that's when I started with the practice. Absolutely loved it. And, orthopedics was just always, a love because of my history prior to going to school to be a physician assistant. And yeah, we were lucky to have you there as a PT. It was
Oh my
nice. It was
gosh.
nice.
So tell everybody where you started, like out of high school, because you have two degrees, not one. She has two, and I think maybe three. We're kind of
Yeah.
challenged on that one, baby. Bachelor's and masters, but yeah.
Yeah. So I graduated from high school and I knew that I wanted to do something in healthcare. I wasn't exactly sure what I wanted to do. I wanted to work with patients. And so my first degree, I went out and was physical therapist first. Worked as a physical therapist for 6+ years. Absolutely loved it.
Hated
And
it,
that
went
was
back to school.
very new. Now, you know what I really liked about it? I really, really liked the hands-on. I liked the education. I liked being able to spend time with patients. I didn't work in the outpatient setting. I worked a lot in inpatient rehab, and then Northern Jersey, out in Colorado Springs for a few years, traumatic brain injury units, stroke. I did, orthopedics, general orthopedics as well too. Really, really enjoyed it, but wanted to go back to school. Wanted to get my
Wanted
hands
more.
dirty. I like the idea of, the whole diagnosing thing. But remember, way back then, when I went back to school, we're talking about what, late 90s, and there was no such thing as direct access, right? There was no such thing as,
It's true.
all of these things, which I think are so good with physical therapists now and the vast knowledge that is out there, and things beyond, being an inpatient treating therapist. I felt like it was narrower then than what it is now. And honestly, I don't know that I would necessarily feel that need to make a change if I were in it right now. But at the time, that's when I decided, yeah, I want to go back to school. And so I did, and I applied, and I got into a program, with physician assistant program, going through. I loved it. I loved every aspect of it. I found myself, though, with each rotation, whether it was emergency medicine or obstetrics or pediatrics, I was gravitating toward the musculoskeletal,
That's right.
problems. And
That's where it's at.
that's really what I wanted. And so despite loving everything and getting a few job offers, I knew that I wanted, to work in orthopedic
Okay.
surgery. So I've been there in orthopedic surgery since 2000. Yeah.
What are we in? 2025?
Here we are, 2025.
Girlfriend.
Yeah.
Yep.
It's just the years.
So we've seen it,
We
right? We have
yeah.
seen it,
Things
and
have changed.
they have changed ridiculously much. But I will say, in my career, there's very few people. There's a lot, but in the grand scheme of providers, very few people that resonate with me as much as you do. With keeping it real, people. She
Yeah.
keeps it real. She takes the really hard stuff, the intelligent clinical information, and breaks it down appropriately so that patients feel not only heard, but also seen and cared for.
And I think that's the important thing that we sometimes forget a little bit. Like whenever, like, it's kind of cliche a little bit to say, "Oh, medicine's changed so much," and over whatever.
Yes.
And it's true. And sometimes the frustrating part as a provider is some things are insurance driven, right? I'm sure you feel the same thing. Sometimes things are, there's some good and some bad things about social media. Patients, may have some expectations which may or may not be accurate based on what you're seeing as a clinician, what their diagnosis is, and so that can be a challenge, as well too. But I think as far as things changing, there's a lot more with our patient population, if we look at it that way, that has changed a lot. Back in the day, for look, joint replacements, let's just say. Oh yeah, well, how long is the joint going to last? Or most of our patients would
Yeah,
be,
because we would talk about it, right? Like,
uh-huh,
you don't want to get it done until you're like late 50s,
yeah.
60s because the wear out rate, you didn't want to have it redone.
And at the time, when you would have somebody would come in that would have knee pain, and you would do all the non-surgical treatment and workup and et cetera, a lot of time the folks, had a few birthdays at that point, and then maybe they were in their 70s and 80s. But now I find that their patients are coming in earlier and their younger ages. And I think that's one of the challenges and changes that are happening in healthcare. And then I like to think about, like, okay, let's think about the why. And not only that, so then get into the whole idea of preventative type stuff. And then you think, okay, well, all right, so just because this joint can be replaced now, is that the best thing? Okay, all right, maybe it is, because we have different types of implants and different ways of approaching, the long-term treatments, that there's longevity there. And
Uh,
why are they coming in at earlier ages? So when you think
I'm
about the whole person.
terrified, and I'll share only because you already
Yeah.
know and have been so kind in helping me.
Oh.
But I have a horrific right hip, and Kristen's face will say it all if
Mm.
she chooses to share that the bone on bone action that's happening in my right hip is short of.
Ugly.
Thank you. Yeah, gives it to you straight. Ugly.
It's ugly.
It's ugly.
Yeah.
And I've been dealing with it for years, not successfully really, because it's just progressing.
Yeah.
But I'm hanging on by a thread with flexibility and strengthening and cycling. And just the way that you don't judge me,
Yeah.
because that's a big concern of mine as a health practitioner,
Hmm.
has been just so helpful to let me come to my decisions on my body at my own time, as opposed to mocking me, which some have done in the course of like, just get it done. Why aren't you getting it done? Get it done. What's wrong with you? And you choose a different path, which I
Yeah.
appreciate.
Yeah, I think it's important because you have to think about, like, even like the whole person, and even rewinding before, you show up with this horrible hip and the
Yeah,
bones grinding together. I mean, you
it's
hear it when
true.
you move.
Yes, I know.
Is what you
Stop.
can do. Yeah. We'll spare everybody that, but it's kind but no, you think about that, and I think it does have, and that's what we're seeing. And people, I think patients sometimes think that they're crazy, or they think that, what is wrong with me? Why I'm having this pain, and why can't I do what I want to do? And I think it's a lot different than what it was, say, back in 2000 or 25 years ago, when the patients would show up and they'd be a little bit of an older demographic. Yeah, think about what. Well, I think a lot of it maybe has to do with, okay, so I'm in my 50s, right?
You
Back
are?
in the
No,
day,
no way.
back in the day,
No
shh, don't
way.
tell anybody. But back in the day, it wasn't as, like, way before our time. There wasn't as much of an emphasis on the athletics and the sports. Now, if we think about it, from kids from a very, very early age, and I'm not saying this is a cause, but I'm saying it may have some bearing on things. There's no off season for many of these higher level or even mid-level athletes
Wear out
that are
rate is
trying
high.
to get higher.
Yeah.
And right, and so there's no off season. There might be a 3 or 4 sport athlete, and now we have people who have been doing the same, all along. My son, one of them. And it makes me think, do you do a disservice in that sense? But there are things such as that. I think that we as providers sometimes don't think about some of these things, and so there's preventative things that can happen as well. But um there's a reason behind it, and there's also some progression, though, now, of what can be done about it sooner, rather than putting it off to a point where you then are in a completely different, activity level, and not able to do what you want to do. And I say, once it gets to a point where you've maximized all non-surgical treatment options, and you've kept active, and all of that stuff that once it gets to a point where it's really interfering with your quality of life and you're choosing not to participate in life because you know either you're going to pay for it at the time or the day after, then, then at that point, there's no judgment. It's a matter of you put it off as long as you can. There's no urgency, but then when the time comes and it's like, there's something that can
And
be done.
what is the thing you always hear? Always hear after. Because I hear too with patients. Like what
I can it's easy like for especially for hip replacements. I should have had this done sooner. Yeah,
it's
or like it took me.
always the
Yeah,
case.
yeah,
I wish I would have had it done
hmm
sooner.
yeah,
So, I mean, anybody that's dealing with these things, they have advanced the care so much since we started
hmm
practicing, or I started practicing, which was 99, 2000 when you
yeah,
entered as a PA.
yeah.
And we used to see, oh my God, it was torturous to rehab a total knee replacement in the early
Oh
2000s
gosh, yeah.
prior to minimal invasive work. You
Uh-huh.
remember those days?
Yeah, yeah.
It was
It's
like a 12-inch incision. It was just not pleasant. And I would crank the bejesus out of a knee.
Yeah, and to a certain extent, when you just think about the anatomy and what was done and why it was done, it makes sense. But at the time, it was standard of care, and now being able to do that without cutting and splitting the quadriceps tendon, and really kind of working in a much smaller window in order to have, say, the knee replacement that the implants still have, a longevity. In fact, the longevity of the high dense, high gloss polyethylene liner in between is even better now than what it was back then. But the fact that you're disrupting less means there's less scar tissue, which means there's also,
Improved range of motion
oh
sooner. Oh
gosh, the
my God,
full terminal knee
stupid.
extension to be
Yes.
able to get that sooner and then to be able to maintain it and actually achieve back to where you were pre-op, is much better if you're not cutting that quad, all of that stuff. And a much quicker recovery, less painful recovery. That's where we also focus on for the patients. Again, going back to looking at the whole person, what is their activity level before they're going for
Yeah.
surgery, because we know there's a direct correlation between strength and endurance entering surgery and a less painful quicker recovery after too. So the whole therapy focus, activity focus, quad and hamstring strengthening prior is really it's a huge part of it.
So, I mean, anybody that's going in, and I really had the good fortune. I worked with Kristen for a very long time in ancillary, ways. But preoperatively, we did a lot of pre-op
Yeah,
physical therapy, and I assisted in writing protocols for that to make sure that patients going into the surgery. So the rule of thumb really is, right? The better you are going in,
yeah,
the easier it is coming out,
yeah.
right?
And that's not just physically. Again, I'm kind of like beating the horse, but it's like it also mentally is better for the patient because
Yeah.
guess what? They then own it. Part of it. It's not a matter of the patient then coming in like, oh yeah, I got a really bum knee and I'm bone on bone, and yeah, I tore my ACL at such and such an age, and I even played through college, and the men's leagues. Da, 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 da. Okay, it's
Right,
great,
right.
and it's common, but then things kind of peter off because it hurts, and then things shut down. Our quad shuts down, or and then there's a certain mindset for some folks. It's just they come in, it's bad. Okay, fix me. And it's just
Yes.
like, okay, but
You got to help.
we're not just changing
You
a
have to help.
part in a car. Exactly.
Yeah.
So they have to really own part of that. And so by doing the exercises and the prehab and really coming in really prepared, they know they're used to doing exercise at that point. They know what it's like to really fire their quads and to really hit, fatigue, or we don't always push them to failure, but to really max things out. And then they're invested, right? They're invested in their, they have skin in the game, I guess.
Yeah, I mean,
It really does help.
that definitely was. So when I went back to school, 2009, something like that, for my doctorate, one of my post grad programming was about, does prehab make a
Oh,
difference
I didn't know
in
that. Okay.
yeah, in joint replacements?
Okay.
And overwhelming amount of research indicating yes, it absolutely does. But to your point, it was more psychological. It was as much psychological as it was physical, and
They're
it was the
prepared.
expectation,
Hmm.
right? Like,
Hmm.
I don't know. And then you come out of surgery, like, oh my God, can I walk? Can I put weight on it? All those
Hmm.
things were addressed.
Yeah. Yeah.
So yes.
It's funny too. I mean, this is very, very, very common because we tend to really focus on it on so much that it's not uncommon because we usually utilize spinal anesthesia rather than general anesthesia. Patients tend to do better. They wake up quicker, and as soon as they're getting any motor back, they're up and walking within a few hours. Right? They go
Okay.
home that day. They don't spend the night in the hospital. So, but they're still kind of coming out of anesthesia, kind of like, oh, wake it up, and they start doing their heel slides as they're there on the stretcher,
Yes.
right?
Oh
And it's
my
just
gosh,
kind
I
of like,
love
and it's kind
it.
of like, and then the recovery room nurses sometimes be like, oh, wait a minute, we got to check your blood pressure again. Like, let's just, and they're like, no,
I gotta do it. I
about it.
gotta
It's
do
like,
it.
oh gosh, it's really ingrained because they're still a little sedated and they're still
Oh,
doing it.
that's
It's a
solid.
that's a good sign. Yeah,
That is
yeah,
solid,
yeah.
like positioning right there for
Mm-hmm.
sure.
100%. Yeah.
All right, so let's go back to physician's assistant,
Mm-hmm.
right?
Yeah.
Because there's a lot of information I think around. So physician's assistant (PA)
Mm-hmm.
is the title, PA/C, right? Certified,
Yep.
right?
Yep.
I'm saying it right.
Certified. Yeah.
Yes,
Except that some would say it's not
license.
physician's assistant, it's physician assistant.
Physician
Mm-hmm.
assistant.
So,
Okay.
but yeah.
Yes, good. No important
Yeah.
differentiation. So slap my
There's
hand on that one.
because there's really
Um,
no ownership there in that. So there's also some discussion about potentially changing, physician associate or
okay.
so there. I
So
know it's a
there's an
differentiation.
independence there. That right?
Yes, it's not a completely autonomous profession. But we do have supervising physicians. We work side by side, collaborating with the physicians. So it really depends on what area of medicine that you work in. So there's a big primary care focus for the educational part of it, but it
Hmm.
is a master's degree, and so for the first half the first year, it's all the didactic classwork and going through with the medical students in different classes from the medical standpoint, and then there's the second part is the focus of all the different on-site clinical rotations. So
Okay.
there are core uh, pro, uh, programs that have classes that you have to do, like OB/GYN being one of them, pediatrics
Sure.
another, family medicine type of, and then there's always the option for an elective. I believe every program has an option for that, but the elective for me was orthopedic surgery because I knew that's an area that I wanted. But I graduated in many. One did an elective in hematology, another one, in
Okay.
pediatric oncology because she knew that that's what she wanted to do, and so it's a great profession. I absolutely
No, I
love
mean
it.
it's upticking like crazy, and we get inquiries now all the time. Now that our staff has grown and whatnot,
Yeah,
and it always comes. Most of the PT people that come here are, I'm doing a PT or I'm going to do a PA, and
yeah,
I'm like, okay, they're vastly different, grounded in the same concepts of taking care of the patient, but
yeah.
I'm not going into the operating room. I love to, but I don't think anybody wants to be picking up a scalpel or anything.
It's a lot of
So,
fun. But yeah,
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 but that's a big part of what you can do, right?
yeah, yeah.
Orthopedically.
So with a lot of the OR stuff, so OR is part of the training for every PA. So even if it's just general surgery and that's all, and they never go into, or they still have to do that as part of their training. So there's the familiarity of not just being in the OR and using your hands and sewing and some of that technique, but then also caring for the patient, post-operatively, the medical end of
Okay.
things too.
Yeah.
But yeah, then if you're really going to work into a surgical specialty, then a lot of that is on the job training, and it's not for everybody. No,
When I was in
but
PT school, the first surgery that I saw, so I was probably 22 years old and observed surgery. It was a hip replacement with the hoods.
yeah,
I got to put the hood on, so I
yeah,
was very excited. Put
yeah,
the gear on, and it was a female surgeon, which at the time was like
yeah,
pretty damn cool because that wasn't a thing. And she had me right next to her. But I'll tell you what, I will never forget when she picked up her carpentry tools, because that's what they are,
uh-huh.
peeps. It's basically like a saw
Yeah,
and a hammer. And she started going to town on the femur for a knee replacement. I about died and was like so excited by it
yeah,
and so fascinated by that process that I went home and Googled up how many years could it take me to be an orthopedic surgeon. And at the time, I was not educated in the world of PA. And I do think that if I was more informed in that, I may have chosen that route as you
yeah,
did.
yeah.
It's pretty badass in
It,
there.
it, 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 it is pretty badass in there. It's a lot of fun. But it's really, really interesting. So we have had some folks that have come through as students as well, and it's just kind of like, the green look, and it's just kind of, it's
Yeah.
not for them, and they're like, I don't like this, and I think that's good too.
Know
That's
what
a
you
fun
don't
little
like and know what
thing.
you don't like. It's like in life,
When
really.
I was
But
in PT school as well, it was the same experience that I did.
mhm.
I shadowed and I watched. It was a joint replacement as well too. It was a few also, and at that time I was like,
So cool.
"Oh, this is so cool," and I
Yeah.
just remembered it, and yeah, I think that probably stuck with me and
Well,
assisted me figuring out my career.
it's also one of the reasons our paths cross more often because I became obsessed with observing surgery early on. And
Yeah,
back then in the early 2000s, you didn't have to jump through the 75,000 hoops that you have to jump through
yeah, it's a
now.
little
So
harder.
you definitely I was able to, submit your resume and have a good reputation, get your shots, all the things, but to stand in there and see, it gives you an enormously better view on how to take care of people when they come out of surgery,
Yeah,
especially the joints,
yeah,
because I had no idea the amount of trauma
yeah.
goes. Now you can watch it on YouTube, but that
Yeah,
wasn't a
that it
thing.
wasn't a thing back then, right? But
Yeah,
now watching it too, but it does give you a perspective of this is what's going on with the
yeah,
patient.
yeah.
This is why, they might be having an issue with this or that, or even things that like, all right, well, if the surfaces are completely, metal and plastic now, then why are they having pain with the weight bearing or something like this? Doesn't make much sense when you actually, you know, think
Have,
about it clinically. It's like, well, yeah, pain with weight bearing is never normal. It shouldn't be normal. If there's pain with pure weight bearing, then there's a problem, right? And then you think that there's something I got to get in touch with the surgical team. So you learn that just over time, but
yeah,
yeah.
no, for sure. And
Mhm.
the experience definitely. I mean, joint replacements are one of my favorite things to take care of.
Yeah.
There are nuances to it for sure, and there is a right and wrong way in doing it. I'm very picky, very picky. Um,
Not a bad thing, though. It's not a bad thing.
no. But let's talk about your teaching because the way
Yeah,
we've been around a while and healthcare's changing and we're both like old school but have to like transition into new
yeah.
school. So I love that you teach. I love that you go back to your school to
I
teach.
do.
And I know
Yeah.
that they love having you teach because I've heard from other people how well attended your lectures are,
It's
actually.
I think part of the reason is because I remember it like it was yesterday sitting in the classroom and number one, on one end being overwhelmed with the information that is being thrown at you at such a fast pace and depth of the stuff and you're thinking, oh my gosh, I got to remember this, I got to know all this, like I'm not, um and then at the same time being so completely bored. I mean,
Yeah,
honestly,
no,
it's true.
it
Let's
is
be
true.
honest. Who
It's
really wants to
school.
sit someplace for hours and hours and hours? So I remember that, the dichotomy of the two, and it's like, all right, I got to do better than that.
Then
Not,
this.
so yeah, it's fun being able to share the information and but then to also really kind of, make it real and give examples
Yep.
and to make it, relevant to what they're actually seeing or what they might be thinking. Like, I know you don't care about this right now and you think it's not important. And I know you think it's not important because of this and this, but here's why it is. And then kind of, loop it back
Do
in.
you feel like you're able to, at least, we've talked about this before we came into the studio here, but like marry the expectation of clinical. I need to know all the things clinically as a new provider and check all the boxes, and that'll make me a really, really good PA or a really, really good PT.
Yeah.
And I disagree, and I'm kind of a snob in my profession, but
Yeah.
I'm curious how you feel about it in yours.
I think we are we're so groomed. Honestly, let's think about it. Most folks that go into the professions and when they're doing it because they love healthcare because they want to help people, right?
Yes.
So you don't want to do any harm. You don't want to hurt anybody. You want to make sure that you're doing the right thing because let's be honest, that patient that you're taking care of, it could be your mother, it could be your son, it could be
Yes.
your neighbor or whatever. And in your mind anyway, at least you're thinking this. So we all want to do well. So that kind of sets our bar automatically high. And then going through programs such as PT and PA
Hmm.
both, It is
They're not
academically
easy.
demanding. So we're used to being high achievers, I think, for the most part,
Yes, yes.
going to school. And so we're used to really pushing ourselves and wanting to know the answer and get the highest GPA.
Yes.
And then you have to get through
Whether it was
class.
me, but I'm just kidding.
So when you set the bar, and then just kind of there's this pressure, and then you come out thinking you have to have all the answers. But the reality is there's no way, no one has all the answers, and there's this lifelong learning that we all have, and that we need to in order to stay up on our game, but then also relevant, but then also more importantly to know what you don't know, and that is where I think
We're in.
that there is a lot of pressure for everybody to know the right answer, and even if you've been practicing for me here
Yep.
as a PA in orthopedic surgery for 25 years, there are still times to this day, last week even, that I'm looking at something and I'm seeing this patient. I'm kind of like, it doesn't sound right. Or kind of, well, let me get an X-ray and looking at that. And it's kind of like, and I know that I'm missing something. It's not making complete sense. And then what do? You reach out to your colleagues. You do your independent research. Yeah, of course. But you also, you talk it through, with other
But you
folks.
you own it,
Oh
right?
yeah, yeah,
You own it. That
yeah.
that's the
You have
that's the
to
part.
100%. Yeah.
You've got to own it.
Oh yeah.
And know what you know and know what you don't know. And if you don't know, it's
Then that's
okay.
absolutely fine. Yeah, I worry more about the folks that feel like they have to know and that they give an answer, even if it's a little bit,
Less than,
yeah,
or
it's like,
not quite there. It fits 7 out of the 8 categories, but that 8th category is a big one.
yeah,
And if it's not fitting in there, not dismissing that 8th one.
right. And then even if you then still start the workup and the
Move it.
treatment toward the
Yeah.
seventh,
Yeah.
and you're
Yeah.
kind of there, but then you're still going to follow up at some point with
Yeah.
the eighth and beyond. Yeah, I think that's
And that,
important.
for me anyway, like when I'm teaching, I teach a fair amount and I'm starting to speak more and more,
Right.
but teaching about that particular thing, just because you don't know, and we know a lot of, I know a lot of PTs that are hell bent on imaging dictating care. And for me, it doesn't, like, I don't need to stop treatment unless it's a traumatic, we want to rule out a fracture. It's,
Right, right.
then okay, maybe we probably shouldn't be doing certain things. But to hold up treatment and then place a patient in the system without some guidance along the way as to what to expect, I feel we do our patients a very, very big disservice in that area.
I would agree with you on that one. They I think deserve, because they're the most important part of the team, right? They have to be aware as to what's going on. But then that brings the challenge when with social media and with some different, maybe not social media, but even just
Yeah.
patients being able to do their own research, they come in with their own expectations, right? And they
Yeah.
come in
Oh
with
yeah.
they know what's going on with them. So
Hmm.
so then how do you handle that?
Yeah, so up in their game, and I still think it comes back around to know what you know and know what you don't know, and give them the straight answers that they're
Yeah.
looking for. So they're arming themselves appropriately. Dr. Google, definitely Chat GPT now. Boy, you can
Oh,
cross reference anything and everything.
yeah.
At this stage of my career, I welcome it because I find it slightly entertaining, to
Okay.
be honest
Yeah.
with you. And I like the challenge. Okay, you think it's this? Well, let's go through. If it was this, you would be seeing this, this, and this.
Hmm.
And we're not seeing that. So let's look at it from this perspective. I mean,
Hmm.
that would be the approach that I would take.
Yeah.
But I think it's a hard thing to teach until you've been around the block a few times, so to speak.
I think you're right about that, because there's a certain amount of confidence that I think has
Get some
to come along
swagger.
with that too, because then the patient may come off as challenging you.
Hmm.
And then if you're not as confident, then what happens? Then you, as a new provider, you may want to shut it down, right? Or the
Sure.
patient
Or
clearly doesn't know what they're talking about or
dismiss.
whatever, and you dismiss the patient. And then what does that do to the relationship with the patient? What does it do to your business? What does it do to your referrals? What does it do to even just the general, I don't
Healthcare.
know, 100%?
Just
Yeah.
healthcare in general.
Yeah.
If you're not listening to your people, what are we doing?
And then that goes against the whole reason why we went into this, right?
I mean, it
So,
does, but it is getting, I agree with you. It is getting challenging, more
yeah.
challenging.
And so being able to
Um,
adapt to that, because that is definitely 100% changed a whole lot over it. But we have a choice. We can either dismiss or we can welcome. And I think welcoming it with the knowledge behind it, or even saying to the patient, you know what, you bring up a
I'm
good
not
point.
sure.
It may have something to do with X, Y, and Z in addition to, what we're seeing here. So let's pursue this a little further and look into it.
I love it. I
Hmm.
love it. So my final question for you, my friend.
Mm.
I mean, I have a few. No, just what? What would you say, since the title of the podcast is Expect More, what would you say Expect More means to you,
Mm.
personally and professionally? And I know you well enough to know they're kind of both the same thing. So
Yeah, they are because it's hard to separate the two
it
when,
is
for some
50
some
years. No, I mean, 20,
wow.
25 years.
Yeah.
Yeah.
I don't know. That's a really good one. I should have been prepared for this, shouldn't I? Uh,
I
I
think it'd be fun.
think the first thing that comes up to my head when I think about what is expect more from me. I should expect more of myself. Really, is really what it comes down to.
That's how I
If
feel.
we can't expect more of a healthcare system, we can't expect more of I don't know, implants that are used for joints. We can't expect more of the surgeons that we work with, or the patients that we treat, or even can't expect more of our kids or our elderly parents or anything until we expect and then follow through with doing more ourselves. And that's, I truly feel that way, honestly. Now, do I need a reminder sometimes? Absolutely. Do my kids call me out and give me a reminder sometimes? Absolutely.
Do your friends call you? Maybe.
Even worse. Yep, absolutely. But that's good. That's a healthy thing.
Yes.
But it is, I think that's really, really what it is, because that is really where our bar is set. And whether you realize it or not, or if I realize it or not, people read where we set our own bar. And I think it's something that we kind of put out there. So if you have a high bar and you expect more of yourself, then that's kind of where things will live around in your
Well,
world, is a little
for
higher.
for me, I told you this a little bit before off camera, but for me, you've exuded that throughout your career, class and charisma and kindness, for sure. But
Thank you.
at my young age, because you are a little bit older than I am, not much, but a little bit.
Yeah.
You and your sister Erin, but I interacted mostly with you.
Mhm.
Gave me hope after practicing for maybe 2 years, where I was starting to be concerned that being a woman, being female in healthcare was going to be really, really difficult, because I wasn't invited to a lot of the meetings and I was blocked out to a lot of things in the early 2000s that were, it was scary, honestly, because I don't have that kind of personality, in case you haven't noticed. And you, in our interactions, you always returned my calls, you always made yourself available, and you were kicking some serious ass in an all male orthopedic practice. And you were the lone female. So for me, I am very grateful
Oh,
that you
kind.
set
Thank
that
you.
tone, and it's something that I've always aspired to. So I just
Oh,
wanted you to know that. And she
thanks.
didn't know
Very
that.
sweet. No, I didn't know
Yes.
that was coming. I appreciate
Yes.
that's really, really kind. It's a good feeling, I think, to not just do something that you love, but to have colleagues in healthcare that you
Yeah.
really like working with too. It really makes all the difference in the world, for sure, too.
I got
So
you, babe,
thank you.
because it
Thank
is
you.
not easy to find all the time. So for us, that's it for us today. This is Kristen Lehman and Andrea Davis. Until next time. Bye.
Thanks. Take care.